everyone. I'm going to talk to you about the neurological devastation of tongue ties. So it encompasses the lens of which I look at all patients with. So the first is that everything going on in your patient, in yourself, at any moment in time is put there and done to you on purpose by your brain for your survival, because the alternate is worse. It's always death, right? So the brain does everything to keep you alive. So no matter how bad you feel, it's on purpose. Rule 2, everything is a resource management issue. Your brain is spending your resources to keep you alive. Rule 3, everything is affected by the quality of your sleep. If you don't sleep, you don't heal, and you die. Rule 4, everything's affected by the quality of gas exchange. We all kind of think about oxygen, but it's the carbon dioxide. And when we overbreathe, we burn out our carbon dioxide and we create kind of bad biochemistry and a whole bunch of other stuff. And rule 5, everything is driven by movement. If you don't have movement, the brain suffers. And so what we're all doing is trying to create appropriate and optimal movement in people. So, to get going, everything I'm about to discuss is actually my hypothesis from the literature and my life's experiences. I had one of those, life-altering moments thanks to Dr. Jones. I took my daughter to her, and she literally woke up the day after her release a different person. She has a diagnosis of ADHD and Asperger's syndrome, and she was awful to deal with. She was terrible to wake up in the morning because she was horribly tired, as it turns out. And so the next morning she woke up happy. She woke up nice, smiley, gentle. She was easy to wake. And it was at that moment I realized the fact she hadn't actually slept pretty much her entire life, which is a pretty horrifying thought for a parent, right? I mean, that was utterly changed my life that particular moment, and I will have a debt of gratitude to Dr. Jones for the rest of my life for helping her. And so this set me off on kind of another journey, because I've had a bunch of them after my first daughter went into autism at 18 months, and that led a whole line of rational reasoning, and then kind of everything's gone. So I wrote the book First Principles kind of to try and actually understand and put out there the continuum of how these things create problems. And so what we're about to do is I'm going to divide the talk into 2 parts, and I'm going to give you the really dry, boring stuff to start with, which is the neurology and some of the epigenetics of how we get to what most of us are seeing in practice, rather than the treatment. You've all heard lots of treatment stuff. I don't really care about the treatment stuff, except precision and the way people do things does make a difference. And the second part is we're going to discuss Natasha. Now, you've seen Natasha looking really good. I'm going to show you Natasha when she wasn't real good. Okay? So we're going to look at this whole thing from a completely different angle. Okay, so we're going to start with a couple of questions. Firstly, is it possible that our combined fields may actually be looking at tongue tie and oral airway maldevelopment syndrome the wrong way? Is that possible? Yeah, cool. Is it possible that tongue tie may not just be a mechanical restriction of and dysfunction of the aerodigestive tract? That's fair. There could be other things. Have we developed the appropriate tools to assess the neurological impacts of tongue tie in children and adults at any age? Anyone? Yes, no? No, probably not. Well, that's my thought. It's my hypothesis that the concept of a tongue tie and all that it actually leads to has been misdescribed. And that we actually haven't gone far enough back to include all the parts that actually comes out as what we can see. And that the tongue tie and the fascial restriction and the mouth maldevelopments, the malocclusions and all the bite irregularities and the breathing dysfunctions are the actual tip of the iceberg that started in the pregnancy, and actually technically about 2 years prior to the pregnancy. So, fundamentally, we're going to talk about the neurodevelopmental disturbance that actually starts, and we can track to week 5 of the pregnancy, and that it's actually going to end up in some of your cases as mast cell activation syndrome. It's going to end up with airway and sleep fragmentation. It's a continuum that you can track, and you can see when the kids are going to get the diagnosis needing kind of silver crowns in their mouth, or ending up at the speech language therapist at 7 years of age, and at 15 years of age they've got a diagnosis of ADHD, and by 19 they've got a near 100% capacity to be diagnosed with anxiety disorder. It's all the same continuum. We're all looking at that elephant in slightly different ways. Now, keeping in mind at weeks 3 to 5 in the pregnancy, the fetus is developing the neural tube, it's budding the face, the brainstem, and the thyroid, which is essential for neurological development for the rest of our life. And the nervous system must develop and connect to the areas that we're all talking about, the cranium, the face, the jaw, the tongue. So the emphasis is, as I said, the brain is controlling everything, yet we're looking at it more from the physical, the thing is wrong point of view. So from that point of view, if there's a disturbance in the movement, in the way that's all connecting, we're going to get a problem in the end outputs. So, as part of my hypothesis, I've obsessed about this particular talk for a really long period of time. And with that, I grew this delightfully silly moustache to try and emphasize the area of the face that I'm actually trying to talk about, which is kind of that area there, right? I actually think we've forgotten the importance of the lower third of the face, this area here. We've accepted it and dismissed it in its significance. And this area is not just about the tongue, the bite, and the breathing. It's a survival area, and it's essential for the development of the brain. Now, the homunculus map, which is what this image actually is kind of a fairly major area, right? It actually allocates 47% of the neural real estate in the brain to the sensory input from here to here, okay, 47%. So think about the rest of the body, it's 53% for all of this. So that's how much importance the human being places on the inputs coming from here to wire up the brain. So that area actually wires the neural loops of the brain, and especially builds the frontal cortex, which actually is essential, obviously, for emotions and decision making. But early on, it's essential for integrating and suppressing primitive reflexes. So wiring the frontal lobes to achieve self-autonomy is actually driven by what are called reflexogenic movements, which actually start with tongue movements, then jaw movements. Now, I'm going to be crass for a moment, because that's in my nature. So, what we know is that men tend to be considered kind of led around by our genitalia, right? That'd be a fair call in a lot of cases. So what I want you to look at here is how small the genital region is compared to the size of the tongue, right? Not very important from the brain's perspective. So maybe we should be focusing more on that particular area. Okay. So what we're going to talk about now is several primitive reflexes, because the primitive reflexes are essential for our development. And so the ones I want you essentially to be aware of include the Moro reflex, the suck, swallow, breathe reflex, the asymmetric tonic neck reflex, and the tonic labyrinthine reflex. But all of them start with the fear paralysis reflex. And that is at about week 3 to 5, depending on whose work you listen to. And the fear paralysis reflex is for protecting the mother and the child from imminent danger, okay? It later goes on, as it's thought in the literature, to become the neuromuscular controller regulating the airway in the phase of REM sleep. So if there's a hiccup in your neurological development and how you integrate your primitive reflexes, is it possible we could actually get a significant problem controlling our airway in REM sleep? What does that look like? What do we call that? Obstructive apneas, central apnea, right? You collapse the control of your airway in REM, you're going to come up out of your sleep, aren't you? the brain will literally shake you. Think children falling out of bed, right? The brain couldn't raise enough force to get the airway open by bruxing or grinding or clenching or any of the other movements. So it picks the child up and throws them on the floor. This is restless legs in motion, and there's a whole lot of reasons. As we heard about it being a dopaminergic pathway, the primitive reflexes are what wire up the dopaminergic pathway. So if you have a problem with these early reflexes, you're going to end up with a neurological control problem for all of those physical things that come later. So, during the pregnancy, the fear paralysis reflex actually protects the dyad by restricting the baby's movements. It stops the blood supply to the baby. So think about that from the threats that are in our environment, you know. Things like mum doesn't have enough money, an abusive partner, the amount of EMF in our environment, air pollution, all these things will drive threat in the mother's system. The fear paralysis is not about protecting the baby, it's about protecting both of them so mum can run away from the danger. So it takes the blood supply from the baby and sends it to the mum's system. So think of our world. We're in chronic threat these days. We're not in nice, calm, happy places. So the motor and the asymmetric tonic neck reflex are the gateway primitive reflexes. If they're broken, progression through your neurological processes doesn't work. You don't go smoothly through it. You go from point A to C to F to G to whatever to get there, because if you don't get there, you will die. You cannot run your brain without these things developing you. You turn into a cabbage, unfortunately. Now, the ATNR yokes the eyes together. It wires up your vestibular system. It drives our position sense, so we know where all our body parts are in space. It controls every physical movement in our development, and if it's not working properly because you haven't progressed through fear paralysis, you haven't got a suck, swallow, breathe or a Moro working, nothing develops past that point optimally. Okay, so there's your 5-week-old human being, and what you're getting to see there, that is your nose, this is the jaw budding off, and there's your oral cavity at that moment. It's an interesting thing. So where I want to talk here is that there's some really cool researchers, including Robert O'Becker, MD, and Andrew Marino, who actually have studied EMF's negative impacts on the growing fetus, and especially from things like cell phones that we all have, and Wi-Fi, and a bunch of other nasty things that we all so happily have in our environment. Now, air pollution, which I've heard can be a real problem in California at different moments in time, is also shown to alter placental DNA methylation. And it affects genes involved in the metabolism of the child, circadian rhythm from air pollution. So that child can be set up for sleep dysregulation because mum was living in an environment with high levels of air pollution and particulate matter, including diesel black and epoxy resins and all sorts of other nasty things. And these things can drive inflammation in the child, causing brain and body and behavioral disorders, including ADHD. And so altered and increased placental methylation of these genes is actually linked to things like low body weight and small for gestational age and a whole lot of craniofacial maldevelopments. Now again, these factors affect the development at week 3 to 4, which is the same point as the primordial face is developing. So you screw up your methylation targets and the blood supply, you are going to end up driving developmental issues in your children. Okay, so by week 10, we've jumped forward a little bit, the development of the fetus's tongue, face, fascia, jaw structures is complete, and it will start having rhythmic movements going on, and the limbs start to move, and this is where the ATNR actually starts to develop, and that movement, especially of the jaw, starts pulling on the cranium and driving the cranial bones development. And so by week 20, that is all kind of set, and the child's going to spend the rest of the pregnancy practicing a suck-swallow reflex to create a viable suck-swallow-breathe for soon after birth. But what if there's a developmental issue such as a tongue tie? The whole movement is going to be aberrant, isn't it? So that child's going to have a compensated mechanism for half its life, right? Until it comes out, 20 weeks from then, that child will be practicing a suboptimal function. Because if it doesn't, what's the end outcome after birth? Death, right? You can't suck, swallow, breathe. You're going to die. Every part of this is a survival mechanism. So as per Dr. Kevin Boyd's work, which he graciously allowed me to have, we can see malocclusion starting by 20 weeks. See the step back jaw. That is tension and restriction and maldevelopment of the craniofacial structures. And that's 20 weeks, and we can see it. Therefore, if you can see it there, we can actually start getting ready to want to intervene soon after that child is born. Because the sooner we start altering this, the better off for the rest of the child's neurodevelopment. Not even tongue, mouth occlusion. Those things are great. But if the brain doesn't develop effectively, you don't have the same quality of life. So this is the same child, right? That's at 20 weeks, and that's after birth. And you can see the same facial developmental structural problem has continued on. And the longer you leave it, the longer it's going to continue to take the child away from optimal development and create many other problems. So, as I've said, suck, swallow, breathe is a survival die reflex. It's essential to time the oral structural use with breathing to stop aspiration when the child's ingesting nourishment. And if that doesn't work, again, what's my favorite word? The child will die. Right? Especially in a pre-modern time, right? So nowadays, we've got a lot of cool things that actually make that work properly. But, you know, go back even as much as a couple of hundred years, if this was occurring, those children are going to have a really hard time, aren't they? So, a tongue-tie restriction deviates them from optimal function. This leads the child to practice maldevelopment compensatory mechanisms to achieve survival and growth. Now, the solution for them may actually involve like a head jutting position or posturing in some strange way. It's whatever is necessary for that child to make something work. Hence, we see strange compensatory actions in our children, and they continue to grow with them because that's their normal. The whole point is to stop aspiration. It's a major threat to life, isn't it? Okay, so compensatory reflex action changes the normal wiring of the frontal lobe. You're not going from point A to B, you're going point A to wherever to get to point B. You still have to get there. And this causes retention of primitive reflexes. And primitive reflexes, by definition, are involuntary motor responses that emerge during, as mentioned, early gestation and continue through, theoretically, till about 1 year of age until you're standing upright. Once you have upright walking, most of your primitive reflexes should not be there. Therefore, when they say up to 3 years of age on the chart, it is wrong, in my opinion. You should not have a Moro or otherwise at 3 years of age, let alone, say, in a 25-year-old or some of the people I played with this weekend. They're survival responses, okay? And if integration hasn't occurred because there is a threat to that child, such as occlusion of the airway, refluxing, etc., it's going to change the development. And the fundamental point is the necessity for the reflex will maintain until the threat to that child, that human being, has gone. Thus the reason why we will see these problems in our adult population. So, think about it from an airway point of view. When the airway is at risk of occlusion and collapse, fragmentation, the child's brain is going to drive a compensatory protective response. It's essential, isn't it? It could be crunching and bruxing, it could be twisting, it could be anything. The child's brain will do whatever it takes to get the airway open. Now, notably, we find these things typically occur at night in sleep, and we'll find them commonly in the REM phase, because commonly the fear paralysis hasn't gone. Now, obviously, this is also going to imply a lack of conscious awareness. So, right, now what I want to talk about is The motor reflex is linked to tongue development, and it serves as a vital communication tool. It employs a whole lot of non-verbal signals to the parents. So from a motor response, the child will do this to start with, won't they? Now, if the child is threatened in its environment, it's going to do this so that it's communicating to the parent to pick them up so you can run away with it, isn't it? These are evolutionary things built into us. The child is practicing these responses as a baby so that they can do it long term. And so oral activity is strongly linked to this and strongly linked to the development of the vagus nerve and other functions in our brain. And if these things don't work properly, we get chaos, okay? So I want to talk briefly about kushi sabishi. This is a Japanese concept, which is I eat because my mouth is lonely. I graze, I just keep putting food into my mouth. You know, teachers sitting there in the staff room marking papers, and they're marking away and they're just slowly eating crisps or chocolates. I've got patients that do this. And this is because their systems have low-grade chronic stress. And this is mouthing that babies do. And it is because there is a maldevelopment and commonly undiagnosed tongue ties in them. Mouthing, like suckling, is a survival response to actually have nourishment go in and activate the calming centers in the brain. Think, in a fright scenario, we give babies a breast or a pacifier, don't we? We calm them down by suckling. But it's not just suckling the action. The pacifiers don't work. It's when food hits the stomach at the same time as the suckling action, you get the release of oxytocin. So therefore, consider a child with oral restrictions. Inability to move the tongue is going to mean that their suckling is inefficient and they may not be driving that oxytocin release. And so interference with these networks driven by interference in the tongue movement causes alterations in how the brain pathways for calm actually wires up, leaving children stuck in a chronic fear response, although they might not realize it, because it's their normal. They compensate to how they are. They wouldn't describe themselves as threatened at any point in time. Now, my crucial point here is that tongue movements influence the ability to affect neuroemotional development from in utero all the way through. Thus, we need to kind of look at these things earlier. So, again, primitive reflex retention causes aberrant behaviors physically as well as cognitively at any age, right? The patient that I'm going to show you is 25 at that stage and had full primitive reflex retention. Now, again, I believe that this is partially because the tongue tie actually disrupts the suck-swallow-breathe mechanism so much that it leads to maladaptive wiring of the oxytocin releasing networks, and as I said, that impacts other neural networks in the brain. Now, what's oxytocin for, right? It promotes social engagement, well-being, it has a stress-relieving effect, and it promotes pro-social behavior in people and resilience. Some people say it provides confidence, and other people say it's a love drug. It's not a love drug. But oxytocin's release is anxiolytic, and most importantly, it actually drives the connection of the raphe nuclei and the striatum. We know what they are, right? That's the release of serotonin and dopamine to keep your brain happy and to keep you motivated to do things in life. Now, these neuronal pools also help us yoke our eyes together. It develops the corpus callosum, it drives confidence and resilience, and again, pro-social behavior. So if you think about autism from that point of view, most of those kids are likely to have oral maldevelopment syndromes, including tongue tie and facial restriction and movement disorders, that are stopping their brains developing the normal pathways, and we're looking at it as a separate thing out here, and it's not. It's this continuum. So we're going to have a brief aside here, and we're going to talk about mast cells very briefly, because I'm about to talk about mast cells anyway. But what I kind of want you to think about just on this point, apart from taking the photo, is that mast cells are everywhere at once, all the time, and they're there to protect you. And I want you to think about eating a hot chili, right? So you eat the food, goes in your mouth, and it hits your stomach, and what happens to your nose moments later? It fucks up, doesn't it? It starts to drip, and you kind of go, wow, that's a great chili, and you feel hot and kind of have a slightly threatened sensation. And that's mast cells in action, and they drive a whole bunch of really interesting things. Now, ordinarily, I was going to say here that I would leave the talk about mast cells to my companion, Dr. Mark Westaway, but you get stuck with me because he was unwell and couldn't attend. But part of the reason why these things are so very important is because mast cells, I believe, serve a real important part in my patients' problems, and they were driven because of fragmentation of the airway, fragmentation of sleep, and chronic threat response, driven by the tongue tie that she had in the first place. She was born with the tongue tie, occluded her airway every night to some degree for her entire life, keeping her system chronically in threat. But that drove, allergic rhinitis, non-allergic rhinitis. It drove weight gain. It drove all sorts of different problems. So, without further ado, we'll jump on, and I will bring you to Natasha. Now, fortunately, Marjan has already given a whole lot of the information that I don't need to actually do too much on. But what I want to show you is I want you to look at these things here because they're important as mast cell irritants. These are stressors that will drive mast cell degranulation in your patient.
Can you go back to that?
Oh yeah, sure.
The drugs will drive it?
No, the stuff at the top above the drugs. The drugs are just there for that's what she was on. But the glutens, the sulfur drugs, the food colorings, food additives, preservatives, molds were a big one for her. There was a purple drink that literally a sip of it pushed her into a seizure. Alright, so there's her diagnoses. Again, you can see snoring and hypopneas, and hypopneas are worse in my opinion than apneas because they drive so much more oxidative stress. They are a reperfusion injury in motion. So a child with a tongue tie that's fragmenting their airway is creating a reperfusion injury and oxidative stress and oxygen deficit to the brain from the moment they come out and start doing it, okay? And as you'll see, cognitive regression during and after seizures, which I'll show you in a minute. Okay. That's one of the seizures. I'm going to show you a few more. She suffered, as noted, about 100 of these things a day, varying from full absence to epileptic seizures to, as I said, toddlerdom regression. She couldn't work, nothing works well, and she reported it worsening over the course of her life, but especially the previous 7 years.
I feel like it's worse with the camera on.
I don't like it.
Okay, well, this is giving a fair indication. Passing out, loss of muscles, big twitching. So we're going to turn the camera off now, okay?
Yeah.
Okay.
Yes, so this is Natasha. That is her. That's okay. No, this is her as a 19-year-old. That is her having a seizure. That's technically her trapped in a primitive reflex cycle at the age of about 3 in her brain, her language, her words. So this will last for a period of time after her seizure. She cannot function, and then like 90 minutes to a day later, she will come out of it and regain adulthood. So, as an interesting one for that, heart rate increases from overexcitement or activity, walking, a few other things, can trigger an episode and push her into a seizure. So she has a very considerate partner. But what I want you to think about with these things is consider the impact on trying to manage a relationship from the fact that if my heart rate goes up, I will blow into a full-blown seizure. Right? It's a neurological consequence.
I get excited.
Right? So again, this one's really important because that arm movement is what was the major trigger. Now it doesn't show well there, but there's Evie actually doing the work at that time. That movement is actually a Morrow response. So she is not having a functional neurological disorder. She is stuck with a Morrow response that she has looped into and cannot turn off. She slept mouth open, snored, oxygen desaturation was significant, and as noted, I determined her to have oral restrictions as well as retain primitive reflexes. The ENT determined a deviated septum and she collapsed her airways fairly significantly. And again, had been worsening her whole life, and it is creating the mast cell activation syndrome. Because loss of oxygen is a threat to life, and mast cells want to save you. And so they loop and wind up and loop and wind up. Now all of that continues to create inflammation and decreases oxygen to the brain, which creates a worsening doom loop. So that's the basic tests that I wanted to show you that I did prior to. So the one that's really interesting at that particular moment in time is that the ATNR was a 2 and a 3. Now again, should a 25-year-old have an ATNR there? Is it normal?
No.
Right? Should it have yoked up by about 1 year of age? No, absolutely. So, I co-managed with Dr. Jones. I focused myself on trying to work on the retained primitive reflex, reduce brain inflammation, improve oxygenation, airway function, as well as do neurorehabilitation. And so we were focusing on trying to strengthen the right brain as a major impact for her because it wasn't working particularly well. Lots of the deficits and weaknesses were left-sided, which is a right brain problem at that moment. We did vagus nerve stimulation and craniosacral adjustments. And we did 14 sessions of neuro rehab, and that's kind of a very brief synopsis, and people can ask me more questions later, but we did things like hyperbaric oxygen. We stimulated her tongue very directly with a electrical probe at 60 hertz to try and actually start setting resting heart rate for her. We did pacing, tone pacing and heart rate pacing to get her up the hill again. And we created a miracle, right? So she improved, major changes to her breathing, to her ability to engage her muscles, and functionally, like one of the highlights for her was that she was able to sit through a 3-hour film, which she'd never been able to do, and then went home and cooked dinner. She didn't have to wear sunglasses either inside or outside anymore. And if you look, what are the ATNR numbers now? 0.5, so barely anything, and I was suspicious that it was just an artifact, and 0 the opposite way. 6 months, gone back to working, done really well. She's only had 1 episode since then, which was overdone. Now, the concepts here by summary that I want you to think on is that without me recognizing the primitive reflexes and the tongue tie and actually getting her to an expert to deal with her oral restrictions, and in my opinion, I believe the style and how Dr. Jones does her release was imperative, because I have other patients go to other practitioners and not get the same results. So that's an important clue. But if we hadn't managed her as a neuro case, as against a restriction, I still believe she'd have been locked in the cycle. Because if you don't prime the brain to actually come out of the cycle, as soon as there's a big enough threat, the primitive reflexes will come back to play again, because she's had 25 years of them looping and looping and looping. So I implore you to consider that the size and the tension and how the tongue tie looks and feels might not be enough. It might not be the best indicator for whether you should intervene. Those line ball calls may actually still be a neurological consequence in motion, and that if we don't actually intervene in every one of them, we can set them up for major troubles long term. Perhaps we need to look at primitive reflexes and whether they're retained, neurodevelopmental indicators, her oxygen saturations, heart rate variability, Could we add these things to our algorithms? I would like to hope we can. So leaving a child with a mild tongue tie may trap them in a doom loop and allow them to develop health deficits along a continuum that is predictable. We need to assess for the other impacts that this thing is having, because it is a neurodevelopmental disorder. It's not just a physical restriction of the airway, digestive tract, and mouth. Thanks. There's the references.